Welcome everybody. My name is Ádám and I would like to present you my 18th progress. Here you can see the members of our team. And I would like to highlight you my vision, and I really believe it in. Endometriosis-related pain should be a concept of the pain of the past with one pill a day. Both of our projects dealing with endometriosis, but the first one is focusing on surgical interventions, and the second one is on medical management. Let's start with my first project, which is comparison of robot-assisted versus conventional laparoscopy for treatment of endometriosis. It's a systematic review and a meta-analysis. Did anyone ever seen a woman suffering like this? Of course, we would like to help her. Indeed, very often endometriosis be the cause behind this. Endometriosis carries a high individual and society cost. There's a high pressure and growing need to treat endometriosis with most appropriate and highest quality care. There's a lot of therapeutic options, but at this time let's focus on surgical interventions. We have two options. The first one is conventional laparoscopy, which is the gold standard therapy. And we have another option, which is a newer, rapidly spreading technique, robot-assisted laparoscopy. We have a third option, but it's just a rescue option, laparotomy. We use this if we have a serious complication in the previous mentioned techniques. What robot offers to us? Reduced pain, less blood loss, and so on. But my question is, can we observe these advantages in the everyday practice? And that's why we would like to compare REL and CL from the endometriosis surgery regarding perioperative outcomes. Our clinical question was, is REL safer and more effective than the CL in the field of endometriosis surgery? Our population patients who underwent surgery for endometriosis, we compared REL and CL, and our outcomes is the different perioperative outcomes. Of course, our hypothesis sounds like REL is superior to the CL in the field of endometriosis surgery. At the end of the whole process, we would like to turn this knowledge back to the bedside and improve the surgical treatment of endometriosis. We conducted a systematic search. At the end of the process, we got 13 eligible full text. Here you can see the list of our perioperative outcomes. And to our surprise, we did not achieve the result what we were expecting. We couldn't substantiate the difference, the previous listed advantages during our investigation with numbers. Moreover, the difference between the two techniques, we couldn't find any significant difference except for one. And surprisingly, in that particular aspect, the result was unexpected. That's why I bring you this figure, and the operative time. And what we can see here, we measure it in minutes from the skin incision to the wound closure, and we can observe approximately 30 minutes longer operative time regarding REL, and this is not what we are expecting. Our main strength is there's a new outcome, which is the operating room time, and maybe the main limitation is we had a lot of retrospective studies. So what does it mean? In conclusion, for endometriosis surgery, REL does not have statistically demonstrable advantages over CL in terms of perioperative outcomes. In practice, we should choose CL first, and for implication in the future, we need to investigate the medio-economic impact of these two techniques and need to perform more randomized studies. Here you can see my brilliant visual abstract, and I would like to express my gratitude to everybody who has participated in this project. It's already published in a D1 journal. Let's turn to my second project. Now, that we know how to treat endometriosis surgically, let's explore how to help with medicines. Almost every 10th woman suffering from endometriosis, the symptoms can be very diverse: dysmenorrhea, dyspareunia, pelvic pain, and so on. At this time, let's focus on medical therapies. We can divide it to two groups: the hormonal treatments and non-hormonal treatments. Based on the hormonal treatment, side effects need to limit the observational time, because the administration of these type of drugs is 6 months. Here you can see the investigated drug types. The size of the green bubble represents the importance of the drug types, given drug types. Our clinical question was, which is the most effective therapeutic options for endometriosis-related pain? Our patients, women of fertile ages with endometriosis, we compared the different medical therapies. Our outcomes is the endometriosis-associated pelvic pain. Our hypothesis sounds like oral combined contraceptives, as the most widely used, are superior to the other therapies for endometriosis-related pain. At the end of the whole process, we would like to turn this knowledge back to the bedside. We conducted a systematic search, and I highlighted to you the 4 big boxes of my search key. At the end of the whole selection process, we got 47 eligible full text. Here you can see the different pain scales, what we use to measure our outcomes. The most commonly used is the visual analog scale, which is a scale from 0 to 10, and it's very easily, you can use it very easily. I bring you one of my most didactic outcomes, which is dysmenorrhea after 3 months. On the right side of the slide, you can see the connection between the investigated drug types. We have, for every outcomes, we have a forest plot. As you can see, there's no significant difference regarding any drug types, but it's not a rare thing in a network meta-analysis. We have a sucra curve, which shows us the GnRH agonist has a biggest under the curve area. It should be the best choice. But more important, the left side of the slide, which is a ranking probability figure. You can see there are numbers which are not p-value, p-scores, which gives us the probability that the given drug was ranked first among the other therapies. So it's a theoretical number. 1 is the best, 0 is the worst. So as you can see, GnRH agonist is the best options, and the placebo is the worst options. So in conclusion, in case of dysmenorrhea, we should choose GnRH agonists supplemented with oral contraceptives. In case of dyspareunia, we should use oral contraceptives, and in case of overall pelvic pain, we can choose between oral contraceptives or progestin combined with aromatase inhibitors. In the future, we need to investigate dyschezia and dysuria, and need to be perform further randomized studies. We already send it to internal review, this manuscript, and we would like to submit to a D1 journal. So that was me for today, and quid pro quo, something for something. That's my motto. Thank you for attention.
Thank you, and congratulations on already having a published paper. I have a question actually about that one, because you mentioned that your question was if it's a effective treatment. Did you have an effectiveness outcome? Because I didn't see one presented.
So which was the measure, the unit of the effectiveness?
Yes, so how do you define effectiveness in this case?
Yeah, the decreasing in the, do you see the scales what we use? We have a 0 time when we measure the pain severity, and after 3 months and 6 months we made it again, and we have decreased numbers in that pain scales.
And you had that outcome for the first project as well, because you only presented the operating time.
In the first project, oh sorry, because I talk about the second one. No, there's no. The effectivity is measured by just numbers, perioperative numbers, which is not dealing with the patient's happiness or any kind of measurement what you would like to hear, but it's just numbers, and we can't measure the patient's satisfaction.
My other question is, because you measured operating time and you said most of the studies were retrospective. So yeah. I'm neither surgeon nor very used to being in surgery rooms, but I have observed robot-assisted surgeries, and I've noticed that, for example, surgeons sometimes leave the table because they don't have to hold the equipment. So do you think that could have actually impacted the operating time?
Yeah, they could do that, what you mentioned, but I think it's not a fact, but we can need to deal with it. Maybe the docking time is the difference, and the surgeons distribute the patients based on how the endometriosis, the severity of the endometriosis, and it was not randomly assigned between the two techniques, and that could be a bias. And but if we have a simple cyst, we won't use the robot-assisted techniques. We need to use it in difficult cases, and that's why we can't observe the advantages of the robot. But it's not a fact that the surgeon can stand up and goes for 5 minutes to do anything, make a call, for example. But it's not a fact, I think. That.
Thank you.
I would like to ask you that. Why did you choose the 3 months? Why it was like written somewhere in the literature before, or why did you choose exactly 3 months for the treatment, for the efficacy of the treatment?
In the second project.
Yeah, in your second project.
We have 3 months results and 6 months results, and in the literature there's no longer observational time. Maybe in 1 or 2 cases, 8 months or 16 months, absolutely randomly, but the most of the articles investigated this observational time based on the side limits. Yeah.
I have a question also. So if the doctors are using the robot technique, they prefer to use that method. What do you think? Why is that? Because you just told us that there is no difference, and also that the robot is slower.
Slower, but more comfortable.
More comfortable. And it is very important for the doctor, because perhaps in that way they can do more operations. So it is very, very comfortable for the doctors to use that.
Yeah, if you have 3 operations for the given day, and each operation will last 3 hours, it will be 9 hours, and it doesn't matter how you stand in a rigorous position for 9 hours, or you can move any part of your body, and yeah.
But I think it is very important to note that it is very comfortable for the doctors.
In the paper, it was highlighted.
Yes. Okay, thank you.
Thank you. So, very nice presentation. I have a question to your first project. As the experience of the surgeons can largely influence the outcomes, could you account for this parameter in your analysis? Being the robot-assisted surgery, a newer one, and maybe less surgeons have large experience with that.
Yeah. So there's no any unit of the measure to measure this, how satisfy the surgeons with the technique, if I understand correctly.
It's not about the satisfying of the surgeons, but their experience. How many surgeries? So how are the learning curves for this?
The learning curves is shorter than the conventional techniques, but so this. In the articles they just mentioned, the surgeon were well experienced, but there's no any number how many operating did achieve